Assalamu alaikum. I am Dr. Atif Raza and this is your channel Peeds Mentor. In today's video, I will discuss neonatal cyanosis, that is the blue baby. You know, in the NICU, blue is never just a color. Blue is a countdown. It means if you see a baby which is getting blue, so it should be an emergency because one blue baby might simply be cold and another is minutes away from cardiac collapse. And here's the terrifying part. At first glance, they look exactly the same. So, when someone calls you at 3 a.m. and say, "Doctor, the baby is cyanotic," you don't get time to guess. You get 5 minutes to figure out whether this is harmless or fatal. So, today in this Pete's Mentor video, I am going to give you the exact framework that separates panic from precision. So, the next time you see a blue baby, you know exactly what to do. So, first thing first, not all blue is created equal. That is, we have two different conditions. One is acrocyanosis and the other one is central cyanosis. Acrocyanosis is a blue discoloration of the hands and feet only. And honestly, in the first 24 to 48 hours, that can be totally normal. It happens because newborns have immature circulation and get cold easily. So, if the baby's mouth is pink but the feet are blue, take a breath. That's usually benign. So, in acrocyanosis, baby has pink mouth but blue hands and feet. And this is usually normal in the first 24 to 48 hours of life. But central cyanosis, this is what we fear because central cyanosis involves the lips, tongues, and mucous membrane. That means desaturated blood is circulating centrally. Clinically, you will start to see it when there is greater than 5 gram deciliter of reduced hemoglobin. So, central cyanosis means you have a baby with blue lips, blue tongue, and mucous membrane. And this is usually due to desaturation of blood, that is hemoglobin greater than 5 gram per deciliter. But one thing you should remember, if a baby is anemic, you might never look blue even they are hypoxic. And polycythemic babies might look blue even at normal oxygen saturation. So always check the hemoglobin. This is the cutoff value greater than 5 gram per deciliter. If the desaturated hemoglobin is greater than this, you see central cyanosis. But for those who are anemic, might be hypoxic, but you don't have cyanotic baby. And in polycythemic babies, you might see cyanosis, but the baby hemoglobin oxygen saturation is normal. So, always check the hemoglobin before concluding anything else. So, now To fix the cyanosis, you need to understand what's actually causing hypoxemia. In neonates, it almost always falls into any of four physiological buckets. So, there are four mechanisms which can cause cyanosis. So, starting with the pathophysiology, we have four different mechanisms which can lead to cyanosis in neonates. First one is hypoventilation. The baby simply isn't moving enough air. So you have to think either apnea of prematurity or CNS depression, either from the maternal drugs or any other cause. The second one is diffusion limitations. Oxygen cannot cross the alveolar membrane. This is rare in isolation but possible with severe edema. So here there is difficulty in diffusion of oxygen through alveolar membrane. This is due to severe edema, but it is rare in isolation. The third one is VQ mismatch. So, ventilation perfusion mismatch is the third mechanism which can lead to cyanosis. Air is there, but blood isn't, or blood there, but air isn't. This is the most common respiratory cause. So, in VQ mismatch, you might have air, but you don't have blood to carry this oxygen, or you might have blood, but there is no oxygen to carry with this. So, this is the most common cause, including respiratory distress syndrome, that is RDS, pneumonia, meconium aspiration. Fourth one, which is the hallmark of cyanotic congenital heart disease and PPHN, that is the right to left shunting. This is the hallmark for cyanotic congenital heart disease and persistent pulmonary hypertension. Due to right to left shunting, blood bypasses the lungs entirely, and this condition does not significantly improve with 100% oxygen. So remember, if you are giving 100% oxygen to a cyanotic baby, but the child doesn't improve significantly, always think for right to left shunting, that is CCHD or PPHN. Now, we have dealt with pathophysiology, that is the mechanism which can lead to cyanosis. Now, come towards the differential diagnosis. I like grouping causes into organ systems. Here is a simple mnemonic, that is R.C.H.M. R is for respiratory, C is for cardiac, H is for hematologic, and M is for CNS or metabolic. So, starting with the first one, that is respiratory. These are the most common culprits, which includes respiratory distress syndrome, which usually affects the preterm infants having surfactant deficiency and ground glass appearance on X-ray. So, affecting preterm having surfactant deficiency and ground glass appearance on X-ray. Second one is TTN, that is the transient tachypnea of newborn. This usually occurs in term babies which deliver via C-section and resolves in 24 to 72 hours. So this is for term babies delivered via C-section and resolves in 24 to 72 hours. Third one is MAS, that is meconium aspiration syndrome. In meconium aspiration syndrome, these babies are usually post-term. Meconium stained fluid is present and the lungs have patchy infiltrates on X-ray. So these are usually post-term having meconium stained fluid and patchy infiltrates on X-ray. The fourth one is pneumonia or sepsis. Any sick baby with respiratory distress. Now the second one is cardiac. That is the heart. These are the critical ones. We use the mnemonic of 5 T's to remember this. The first one is truncus arteriosus. Second one is transposition of great arteries, which is most common cause in the first week. Third one is tricuspid atresia. Fourth one is tetralogy of Fallot, and fifth one is total anomalous pulmonary venous return. So, first one is truncus arteriosus. Second one is transposition of great arteries, which is the most common cause in the first week. Third one is tricuspid atresia. Fourth one is tetralogy of Fallot. And the fifth one is total anomalous pulmonary venous return, that is TAPVR. But do not forget ductal dependent systemic lesions, that is HLHS, hypoplastic left heart syndrome, and the critical coarctation. These are the cardiac. The third one is R is for respiratory, C is for cardiac, H is for hematologic. So, in hematologic, we have babies which are polycythemic, that is hematocrit greater than 65%. Methemoglobinemia, which have chocolate brown blood and saturation usually stuck at 85%. Sats usually at 85%. Now the fourth one, that is CNS and metabolic. It includes seizures, hemorrhages, hypoglycemia, hypothermia, and any other cause which can lead to CNS depression. So, up till now, we have dealt with the definitions of acrocyanosis or central cyanosis. Acrocyanosis is usually normal because of physiology. We have dealt with pathophysiology, which have four mechanisms: hypoventilation, diffusion limitations, ventilation perfusion mismatch, right to left shunting. Differential diagnosis, which includes respiratory, cardiac, hematologic, and CNS. Now, comes toward the diagnostic approach, which is most important on the bedside. You are on the bedside. The baby is blue. What do you do? We have a stepwise approach. So, in diagnostic approach, step 1 is pre and post ductal saturation. Right hand is for pre-ductal saturation and foot is for post-ductal. If there is a difference greater than 3% to 10%, always think right to left shunting, PPHN or critical heart disease. So, if there is a difference in between pre and post-ductal saturation greater than 3% to 10%, usually it is greater than 10%, always think for right to left shunting or critical heart disease. Now, after the pre and post ductal saturation, if there is greater than 3% to 10% difference, always consider right to left shunting. After this, we go for hyperoxia test, which is the gold standard. In hyperoxia test, we give 100% oxygen for 10 minutes. And after 10 minutes, we go for pre-ductal ABG. If the PaO2 is greater than 150 millimeter of mercury, this is likely due to respiratory. And if the PaO2 is less than 150, usually less than 100, this is likely due to cardiac or PPHN. After the pre and post ductal saturation and hyperoxia test, go for imaging and labs. On chest X-ray, if you find egg on a string, think for TGA, that is transposition of great arteries. If you find boot shaped heart, think for TOF, that is tetralogy of Fallot. And if the lungs appear ground glass, think for RDS. Always check for glucose because hypoglycemia is one of the cause of cyanosis. For heart disease, Echo is definitive, but do not wait echo to start treatment. While you are doing your diagnostic approach, start management as well. In management, we follow the ABC, that is airway and breathing. If the child is apneic, we start bag and mask ventilation immediately and maintain a saturation in between 90 to 95%. But if you are thinking for PPHN, try to maintain saturation greater than 95%. If the neonate having poor perfusion, give 10 ml per kg of normal saline bolus. And if you are thinking ductal dependent lesions, start prostaglandin E1 immediately. Do not wait for echo. Start PG1 with the dose of 0.01 to zero point 0.1 mcg per kg per minute. But remember, side effect of PGE1 is apnea. So prepare yourself for intubation. Be ready to intubate the child if there is apneic spell. In specific cases, that is PPHN, we give inhaled nitric oxide, usually at 20 parts per million. If you are thinking for sepsis, start antibiotic after sending the cultures. Do not wait for the cultures report. And if you are thinking methemoglobinemia, give methylene blue. Usual dose is 1 to 2 mg per kg. That's all for today's video. That is part 1 of neonatal cyanosis. In this video, we have covered the two types of cyanosis, that is acrocyanosis or central cyanosis, pathophysiology, differential diagnosis, diagnostic approach, and the management part. So here is the takeaway. Always verify acrocyanosis or central cyanosis. Always look for mechanism, that is either this is due to lung problem or shunting. Go for diagnostic approach, that is pre and post ductal saturation and hyperoxia test. Manage promptly, that is secure airway. And if you are suspecting ductal dependent lesion, start prostaglandin E1 without waiting for echo. Cyanosis is scary, but with a systematic approach, you stop guessing and you start saving lives. In part 2, inshallah, I will break down PPHN and RDS management. So, if you like this video, subscribe to my channel and share this video to your colleagues so that they also start saving lives. If you have any query related to this topic, comment your query in the comment box. Inshallah, I will answer your query in the comment box or in the next video. Till then, Allah Hafiz.